Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland. And welcome to this, the 9th in our exciting lineup of QI Connects for 2016. In fact, the 28th since the sessions began. As you recall, QI Connect provides an opportunity for colleagues across health and social care and beyond to learn from international leaders in the field of improvement, innovation and integration. We've designed these sessions to be short, accessible and recorded to allow access at a time that suits all. And in order to make the best out of today, I would like to introduce you to Jennifer Graham, who's going to take you through some tips on using WebEx. Good afternoon, Jennifer.
Thanks, Brian, and good afternoon, everyone, and welcome to the session. I just have a couple of housekeeping slides to get us started. If you can please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, if you could message the BT call manager through the chat function or by pressing *0 on your telephone keypad, and that'll take you straight through. So, these sessions are designed to be an interactive learning experience. So we encourage you to use the chat function to share any questions, comments or ideas throughout the talk. There will be an opportunity for Q&A at the end of the session. And you can just click on the speech bubble, the chat icon there, message, type in your message and then press send. So we did say we want it to be a fun, interactive session, and we're aware that we've got people from around the globe joining us today. So we've actually have I should just ask you to click on the map. So if you just click on the pen icon, you can see circled there in red. Click on the arrow to show where you're joining from today.
Great to see so many people from Scotland joining in. Hi Mike, hi Keith. And with Gyle Square, which is our Edinburgh office, so we've got a group of folks over there. So big shout out to Healthcare Improvement Scotland in Edinburgh. And we've got colleagues joining from across the world. It's just a bit slower on WebEx for their arrows to appear. But thank you very much for that introduction, Jennifer, and welcome to everyone joining the call today. And a shout out to David Grayson. David is a QI connector all the way through to the first series, and David is staying up, or has actually got back up at 4 AM in Waitemata in New Zealand. Big shout out to David for joining us again on this QI Connect. And as Jennifer mentioned, we've got a whole series of people joining us. The organisations now number 468 organisations that register with us to both join us live and use the recordings that you'll hear about in a moment. However, as you all know, we have a competition with a big prize. And the competition that we're going to be going on to is to identify a particular flag. I'm absolutely delighted that we've now got 48 countries that join in with QI Connect, either live or using the recordings. And you shout out the name of a country and we'll look for the first arrow on that country. And the new country that's joined us for the very first time today is Taiwan. Who's to Taiwan? Gordigar. This is true. Chinese flag is on there somewhere, folks, and a big prize coming your way. So you have to make sure that your arrow is working. Let's see, Pauline, well, you know, you're in Scotland, thanks, but no. Well, oh, Gillian's getting close. The Taiwanese flag. Tom close. Keith Burns. Well done, Keith. Keith got there in the end. It's the Taiwanese flag down here, so well done. And Keith, as you know, as a QI connector, you'll be receiving a QI Connect mug. Well done, everyone, for taking part in that. bit of fun. And I'm absolutely delighted to say that, as you'll recall, when we first started the series, we had one slide with all the images of the wonderful logos of the organisations joining QI Connect. This now runs to 13 pages of logos. Absolutely wonderful to see these from all over the world. Absolutely delighted to have you join us on a regular basis. You are the QI connectors. And of course, we're delighted to have every part of NHS Scotland join QI Connect, and great to see so much activity on the chat box from the NHS Scotland colleagues. And we always give a big shout out, as you know, to our university colleagues. And we've got 43 universities now joining QI Connect on a regular basis. And the second page of those universities. And a special shout out to some new organisations that have joined us for the first time. That's the Taipei Medical University from Taiwan in the center of your screen. But we're very pleased to have all of our new colleagues join QI Connect. You're all very, very welcome. And as QI Connectors know, we record all the sessions so that you can learn. Again, these are our colleagues in Koawatea, New Zealand, who were using the early recordings for teachback for their teams to learn about quality improvement. And all of the recordings are easily and freely available on the Healthcare Improvement Scotland website. Please use them and enjoy sharing the quality improvement experience. We're also delighted as ever to be partnering with the International Society for Quality Improvement in Healthcare, ISQua, and the ISQua Fellowship Programme that uses QI Connect series recordings as approved resources in its fellowship programme. Also, to introduce the small but perfectly formed QI Connect team, you've heard from myself and Jennifer. Big shout out to Ross Stewart, who carried out all the administration and provides all of the certification after the event, and also to Alex Sterling, who's supporting as part of the team on Twitter analytics. That's the team that's bringing QI Connect to you today. And absolutely delighted to have joining us today Jenny Wilson, and you'll hear more from Jenny Wilson later in the call. Jenny is a general practice nurse advisor at Scottish Government and also a Scottish Quality and Safety Fellow. And Jenny will be asking the first question of our QI Connect speaker later in the call, and gives us a great opportunity to give a shout out to the new Quality and Safety Fellows, Cohort 9, possibly the best cohort Quality and Safety Fellows ever, they tell me, and their wonderful new logo. So a big shout out to Cohort 9, who'll be joining the call later today as well. Just remember to tweet as you learn the hashtag HISQI Connect and follow us at HISQI Connect. We're very keen on Twitter and very keen to get the word out there, so please help us with that aim. Brings me to a wonderful opportunity to introduce a friend and colleague. Our speaker today is an international leader in healthcare improvement, having had a long and distinguished career as a paediatrician and Deputy Medical Director for Quality at the world-famous Great Ormond Street in London. Dr. Peter Lachman is now the Chief Executive of the International Society for Quality in Healthcare, ISQua. Of his many achievements, he is a co-founder and chairperson of the Paediatric International Patient Safety and Quality Community, roughly known as Pipsqueak Community. And it gives me an opportunity to give a shout out to Genevieve Paisley, who works tirelessly at the Hospital for Sick Children in Toronto on the Pipsqueak programme, and a friend and colleague of Peter. So it remains for me just to welcome Peter to the call. Good afternoon, Peter.
Hi, Brian, and hello, everyone. Thank you for inviting me to get into the show. It's a great honor because basically what I'm proposing to do today is to give some reflection on my experience in quality improvement and patient safety, to be a little challenging and to hopefully get you to think in a different way. It's also an opportunity to reflect on my time at ISQua and to see what ISQua should be doing in the future. So I'm bringing this all together. Just to say the New Zealand people, I did a version of this talk in Kauakatea. I was visiting there a few months ago, and they may understand the way I'm moving forward to try to connect leadership and networking. So the talk's about leadership and how can you really make change in the future. Basically, ISQua, just for those who don't know, is a non-for-profit organization founded 30 years ago. And our mission is to really inspire people to improve and to ensure that there's safety worldwide. We started really in the accreditation field, but we moved further away into more areas that involve patient safety and quality. We have education programs, as Brian said. We have a conference. We've just come back from Japan where the conference was successfully held. And next year it's in London. So for those of you around, that's a conference to consider, and in Kuala Lumpur. We have the foundation, which is on external evaluation, and a membership organization are dependent on members to make sure that we remain vibrant and strong. So that's basically ISQua with its 4 pillars. And when we look where ISQua is going in the future, it's going into an area of really considering what the real aim of high-quality person-centered care is. In fact, that's the first question to all those who are listening, is what really is the aim? I'm quite fortunate to be an IHI Health Foundation funded fellow just 10, 11 years ago, and it's always amazed me that for the first 2 years of my career as a doctor, high-quality person-centered care was taken as a given. We just thought that happened. It is in the last 16, 17 years that quality improvement and patient safety has become something that we talk about. When I was at medical school, this was not on our agenda. So really the question is the real aim? Now, I think that we've really got to think about it in terms of person-centered care. This is the ISQua model based on the Institute of Medicine, 6 domains. But the center is very important about this respect and holistic partnership, which is compassionate. For me, from the patient safety and the reliability theory, high-quality care is quite simple. The person happens to become a patient, needs care that has to be right the first time, every time. I think if you reflect on the care that we provide, it definitely doesn't meet this criteria. So, person-centered care means right place, when, how, and when the person requires the care. It's the right caregiver appropriate to the needs of the patient or the person. It requires the right treatment to be given all the time, not only sometime, and not dependent on who's on or who's seen the person. It requires a system that has no delays at all. You get the care when you need it, not when the system can deliver it. Care needs to be coordinated and safe. If hospital, care needs to be in the right place, not in the wrong bed, which is often the case. And even standardized care, it should be personalized to the individual needs of the person. Now, this care is really what person-centered care is about, getting it right all the time. Now, what puzzles me is that we don't do that. I put up this model here from the Health Foundation, which really summarized it comes from a paper by Alf Collins, which you can download on coordinated, enabling, personalized, with dignity, compassion, and respect. That really matters to people. What puzzles me is, sorry, I'll go back one. What puzzles me is that we accept the inability to deliver the care as norm and reflects what goes on in our hospitals and our healthcare system. We tolerate poor care, even though we know that it's wrong. Why is that? What is the problem? Well, many people give perceived problems. They talk about limited resources. We won't be able to do this without more money, more people. The press, the staff are overworked. But if you talk to the staff, they'll say so as well. They're asked to do too much. They'll say the problem is that there's increasing burden of demand. We've just written a white paper from at IHI, which you could download, on current burden that aging populations are going to give as more and more demand is put on the service. The absence of the status quo, we can't do much. And the usual problems of process, knowledge, not knowing how to improve, and resource allocation being unequal. Now, I could make this much longer. But also what puzzles me is the third question. Do highly performing individuals, that's as healthcare providers, accept low-quality care? Care that's not person-centered, that's unsafe, and has not good access. This accept as what's going on as the norm, and perhaps we need to really think of what the key issue is. I'd say that the first big issue is the one of culture, of complacency and of accepting this as the norm. In many societies, we have changed this culture. I also argue that one of the problems that we have is the issue of professionalism, the tribalism that we have within our own organizations, within our own professional bodies, doctors versus nurses, doctors versus each other, and not accepting the fact that there needs to be a new form of professionalism in the future. Really what has to happen is we have to think about how we're going to change in the future. I've adapted this from an IHI paper on major changes. This way is a new way of thinking. I've put this because I'm trained in the work of Edward Deming, that we need to think differently. We cannot continue to apply the same solutions to the same problems. And that means we may need to totally redesign the system that we have. You cannot have community-based, person-centered care if we train our doctors in hospitals rather than in the community. We expect them to be proficient in the care of chronic diseases. They only manage chronic diseases as acute exacerbations of the chronic disease. This means we need a change in the culture, the way we act, we talk about things, and we learn, and especially the way we teach, the way we prepare the doctors and nurses for the future, and as well as the allied professionals. Finally, we need to actively adopt changes. We cannot accept things exactly as they are. I'm having a bit of problem with this moving on. So it's not moving on at all.
Yeah, Peter, we might just pause on that area there and just check with Sheila from BT and just see if there's any issue with moving the slides on.
I see no issue, but I see we're currently on page 46. If I just take the presenter from you and move on to page 47 now. Not doing it for me either. There may be a technical WebEx. I do apologise.
If you can look into that, Sheila. So, Peter, this...
I can continue talking.
Yeah, sure.
So as we go along. So basically, the key issue is that over the last 10 or 15 years, what happened is that in the quality improvement field, we've got to apply the theories of quality improvement. This starts with the series of Juran, which is basically looking at quality planning, quality control, management of quality, and adding this one of quality improvement, which comes from Deming. Now, it's quite easy in that even though this is a framework that is more than 60 years old, we still don't have it uniformly with our healthcare service. We may look at the theories of Deming. It's also something that is not accepted fully, that we need to have a theory of change, a method of change, and measures. I believe that particularly the systems variation psychology theory of knowledge, our knowledge that Deming has, is a good foundation for change. Yet, if you ask the majority of senior managers or senior professionals within the health service, do they know anything about this or any of the theories underneath this, underlying this, they obviously say no. Also happens if you ask people if they can interpret an SBC chart, as you can see now, unless they've been trained, they would not do so. This is not the norm. These are still the exceptions. Quality improvement is still on the fringes in many places. If we really need to make changes, we need to think of doing it differently. So what really one requires is frontline ownership. In Canada, there's been a movement to imply frontline ownership, which is one of Deming's 14 principles. Basically, that in order to solve the problems, the frontline needs to own the problem first. And often we do not have frontlines that own the problem of change. What do we have to do in order to do this? Really consider why change is so difficult. As I reflected on my career, I think these are the things that really make a problem. Firstly, we still have an issue of power. Who controls things? Where do patients stand in relation to the doctor, or where do the nurses and allied professions stand in relation to the doctors in our healthcare service? Healthcare is still very hierarchical. We know that this exists in many of our organizations, and often this is based on tradition of how it's always been done. People always say, this is the way we do it here. We do it in silos, and it's quite saddening that these silos still exist throughout the healthcare, between primary, secondary, and tertiary care along the patient journey, for example. We took dysfunction. Dysfunction teams are something that we would not accept in other industries and accept them as a norm because the members of the team may be experts in their field. And finally, we haven't really dealt with the issue of professionalism. What does it take to be a new professional? Still a problem here, Sheila. Okay, the new professional really looking at what this distinctive competence is. In the old days, the distinctive competence is that doctors knew more than anyone else about health. Nowadays, with the internet, this is not true. The asymmetric competence is changing, and we define what the new roles of health professionals will be in the future. They require different cognitive skills that we have had in the past. It requires to have a moral commitment to change, a collegial commitment to work together. It requires us to deal with this issue of professional autonomy, which well binds many of us in healthcare. In fact, there's a paper that's worthwhile reading from Alma Berti et al. On system barriers that we overcome in order to get to an ultra-safe health system. I recommend that you look at this paper because although it's a few years old, it still provides us with barriers that we need to overcome and that we have yet to deal with. So how can we do this together? How can we get to a point where this is much better than it is right now? Well, we need a new kind of leadership. A leadership that's prepared to challenge the professionalism hierarchies that we have in the past. We need a vision that shows that we really want to get care right the first time, every time, and we will not tolerate care that isn't. This allows us to give hope. It's very difficult to make change, and we need to have courage to do this. I think the lack of courage is something that is quite evident in healthcare, and to make changes that we really need to do, then we need to make it really something that people are willing to take the leap. Respect is something that is often lacking, and we need to really work on this. This is respect for the people who come for our care, and respect for each other. and to understand that respect is something that is not easily gained when it is lost. We need some skills in quality improvement and patient safety. We still do not train our medical students in patient safety and quality improvement. And it's really saddening that our future doctors are not being trained in the areas that we really need it, and we're doing remedial care. And finally, we need time and space to make changes. So it's quite a tall order, and we cannot really do this alone. I don't think that quality improvement alone is possible. And this is why a session such as this one, with people from around the world sharing their experiences, is so important. But we need to formalize this in a better way. We need to learn from each other, but not simply copy. Contextualization is now key. Things work in one country may not work in another. They may not work in one ward when they work in another ward in the same organization. They may not work with one general practitioner when they work with another. So context is something that we need to study very well in the future. The book on the wisdom of crowds, saying that we have to do this together in order to make change. In many places in healthcare services around the world, there are very good improvement projects that fail to spread. And what we really need to look at now is how can we get the spread going. So what we try to do at ISQua is develop communities of practice. And this book by Etienne Wenger defines this in detail. But a community of practice is a group of people who share a concern or passion, who learn how to work together to solve issues. And I would argue that quality improvement or patient safety is about communities of practice and where we need to go in the future. In terms of network theory, I'm just going to give you the references here. The Health Foundation has got two very good monologues on it that you can get down. And there is the evidence base, mainly done by one of our board members at ISQua, Jeffrey Braithwaite. His team in Australia have really looked at the evidence base for the use of networks in healthcare. And I must tell you that they've been quite critical of networks, because networks are not the solution unless you really nurture them and develop them. My argument here would be that what you do is develop a community of practice and apply network theory to that community of practice. In order to do that, you have to look at many different parts of it. There are a number of networks that are given. This comes from one of the Health Foundation papers. The learning network, and I'd argue that what we have right now is a learning network. The agency networks, which are usually more formalized, these might be the government agencies or different healthcare agencies. Advocacy networks, which are more vocal. We have managed network, which is really about service delivery, and this is often what happens in healthcare. Most of us are involved in social network. As I see the Twitters going off, that's a social network in which we're trying to create some kind of vision. The Health Foundation book that gives three key things for networks, and I'm going to refer back to what Brian did in the beginning. He gave us a demonstration of this network that we are on at the moment. It's critical mass. That's the third point down there. There are more and more people joining the network because it's a common purpose of learning. There has to be some kind of structure, and that's the cooperative structure where there's respect, where everyone's views are valued, and there is collective intelligence. There are over 50 people on the call right now, and everyone's view is valid, important, and is part of this community building. Now, where you have these 5 elements, you have the key foundations for a network. And again, they put through this idea, the importance of diversity. The network mustn't be uniform, because the diversity brings its strength. Leadership is distributed from the center, and even though what's happening right now in this particular network we're on at the moment, the control is coming from Scotland from a group of 4 or 5 people. The strength of this network today will be how the rest contribute at the end. there must be reciprocity of people to make sure that the network does work, and we have to have community building. People need to understand that we're building a community of improvers. We have to filter information to make sure people are getting the right information. At the same time, we have to amplify things that work. So I'm going to example that on my recent visit to New Zealand and Australia, I saw a number of things that worked. How to amplify that everyone learns about it and that can get put into action. Networks really facilitate. They ensure that we try to get to the main points right at the beginning, and they also invest or provide services to their members. So these functions of networks, of convening and bringing people together, is bring together a community of practice that will enhance some kind of aim to improve the effect of good. Finally, I'm just going to show you some issues of effective networks. You can also read the opposites, which are ineffective networks. Really, these are the things that we really want to do within healthcare. So when I go back to the issues that we face, we have healthcare that's not providing the right care the first time, every time, to the people who seek it. We generally find care that is maybe right most of the time, but not all of the time. When you see your healthcare provider, you want to make sure you get the right service. Tolerate things that we wouldn't tolerate in other industries. We hospitals or health services open when in other industries they would be closed, maybe because they're not getting it right the first time, every time. So we really need to change the culture to see where we're going. And really need to do this as a community of practice in which we work effectively together. So in summary, in Israel, we have a number of networks, and I'm showing you where we're going forward so you can see how we will work together. NHS Scotland, NHS Improvement Scotland is part of this network. They're part of membership. A network or community of practice of external evaluation or accreditation bodies with the IAP program and an accreditation council, which looks at making sure that we can have standards worldwide that are constantly improved and are raising the outcomes for patients. Education Fellowship Network, which is a community of practice of people mainly from middle and lower-income countries and some from upper-income countries, are working together to find out what's the best way to learn together in order to improve healthcare. We have our experts who provide expertise to support the other programs, and that's a new area. And we are now developing a quality improvement and patient safety network to get quality improvement and patient safety organizations that normally would not work together to work in a way that is cost-free in terms of high costs, because most times you have to join a managed network and pay a lot of money for it. We really want to say join ISQua, and you can really get something that will be able to enhance your outcomes. And finally, we have two areas that we're going to look at is policy development and research. In summary, what here is that we've gone the last 15 or 16 years applying patient safety theories, refining it, applying quality improvement theories based on those theories of Deming, based on methodologies we learned from other industries, and yet still harm 10–15% of patients. Maybe things are getting more complex, and we're still not managing to provide what healthcare is all about. Provide right care the first time, every time, in a person-centered way. But if we work together, lead differently, we can achieve this in a different way. Thanks very much.
Peter, thank you so much. That was a tremendous run through a whole series of both challenges to systems that we operate in, challenges to our thinking, and some great resources to help our considerations. Now, let me just welcome onto the call. We've got Jenny Wilson on the call. Good afternoon, Jenny.
Good afternoon. Thank you, Peter, for a very engaging presentation. You talk about the importance of leadership in your organisation. One of the areas Cohort 9 is interested in is how you lead the leaders.
That's an interesting question because leaders don't like to be led, in my experience. I think that we really changed this idea of the leaders being able to lead without having the right knowledge and the right cultural values. I think we tolerate a lot of leadership which is more aimed at the bottom line or getting people through a service in the current way. So to lead leaders, you need someone who's able to provide the sense to the leaders that they are leading while you're changing them. Mandela's got a good quote on leadership, which I like, which was, you have to lead from the front, but they think you're leading from the back. So you're behind them, but you're leading from the front. I say to your cohort is that the most important thing is trying to work out what the leaders' real aims are, goals and aspirations, what makes them really tick, what's the intrinsic factors. Part of the improvement program is to try and meet those goals at the same time. If you meet those goals that the leader has to do because some other leader is asking that leader to do that, and I'm referring to health services where most of the CEOs of hospitals, let's say the NHS, in the other four countries, is responding to some political need that they have to do. So therefore, a lot of what they are doing is for political leadership requirements rather than for the requirements of the patient. We have to allow them to deliver that at the same time to lead for change. And that's the trick. And if you do that, then amazing result.
Thank you very much, Peter.
Thanks, Jenny, and for that great answer, Peter. We've got Andy Crawford on QI Connect this afternoon. Andy is Generation Q Fellow and the Head of Clinical Governance here in the NHS Greater Glasgow and Clyde, and he asks, are we conflating leadership with seniority and authority?
Okay, so you've got to be realistic in this thing. Leaders are at every level of the organization. If you notice, when I talk about network theory, I was talking about distributive leadership in the network. And really there's the key thing that you really want to get changed is what I was talking about, frontline ownership. Frontline ownership is when the leaders in the front line, whether it be a nurse, a doctor, a porter, a patient, or an professional, any of them can be a leader in solve a problem. Unfortunately, in the hierarchy that we have and the power differentials that we still allow within the health service, leadership is often mixed up with authority. And the good leader who's ready into change allows people to lead when they need to lead and make their decisions. So, I'll give you an example. Part of a lot of the work I do is working with young doctors and young nurses, and I've got a cohort of young doctors I'm doing in Ireland at the moment. I have a scholar in residence at ISQua and at the Royal College of Physicians, and my job is to teach them to take leadership roles as young doctors and work with people in the front line to effect change and not wait for authoritative leadership to take control and allow them to change. Now, often what happens is that the authorities block, don't provide the time and space for people in the front line to lead for change. And I think that's where good leaders really make a difference.
Thank you. And that touches on an area raised by Lillian Russell, who's a Programme Administrator at the Golden Jubilee Hospital here in the west of Scotland and also involved in running their improvement club there. And Lillian says, hi Peter, is there scope for getting basic improvement science into every caregiving professional curriculum, then add leadership? with theories and ideas of networking, compassion, etc.
Yeah, well, I gave a talk about 2 weeks ago, last week at the ISQua conference just on this. It's 2016. If you ask a medical student or nursing student, are you trained in, just I'll skip one element, do you have detailed training on human factors or process design, on how to improve your care? You'll find they have tokenism at best. Medical school, nursing colleges, and universities who train allied professionals or any health professionals have very negligent in providing the kind of training that people need. I'd argue that if we change the way we train the future health professionals, make a major difference. Unfortunately, it's still seen as a fringe activity. It's not seen as something that is as important as pathology, physiology, pharmacology, and general medicinal surgery, for example. So that's a pessimistic side speaking. I do believe that we as quality improvement people can be activists, make a change. We can demand change. Get the medical students, the nursing students to demand change. We can start doing this. And I think that is one of the big challenges we have, is to engage with the academics and say, you have to make time for this. It's not an option. It's a necessity.
And Jennifer Pennycook, who's the practice development facilitator here in Glasgow, and also one of the wonderful cohort 9 quality and safety fellows, says that in experience where our juniors lead on quality improvement initiatives locally, we see great results, and they continue to support that in Glasgow. So again, to your point around having the people with us still doing the work close to the front line. I have a question here from Adele Sheridan, who's one of our wonderful project officers here at Healthcare Improvement Scotland. Adele asks, do you think our toleration of poor care is linked to us viewing the healthcare system as something very precious compared to the lack of systems available in developing countries, and reluctance to see healthcare privatized?
Yeah, you know, I think that we are but precious in the United Kingdom, and I'm going to give you an example. I'm doing some work with Irish Aid in Mozambique, and I'm going out there tomorrow to do my next lecture with a collaboration of 14 hospitals. And with the Ministry of Health, Mozambique is one of the poorest countries in the world. It has very few resources. Its resources are its people. When I'm working with the teams, I said, what are your problems? And one team said to me, what we'd like to do is improve medical handover. And I said, what is the problem? They said, we have one nurse to 30 patients. What we want is the nurse to know who are the sick patients and how to do it better, and they want a simple solution. I reflected back and I said, well, gee, if we here had more than 1 to 8, we'd be worried. And I started to think that, well, we often think of resource as the answer without changing the culture. I've never seen a group of 80 of multidisciplinary teams so engaged to solve a problem despite the lack of resources. So we are a bit precious. We often think that the solution is technology, new buildings, and more people, where I argue the solution is a bit of that, but more a change in culture, change in professionalism, and a change the way we work together.
Peter, and you touched on technology there, and let me just bring in the point made by Andrew Winter, who's a regular QI connector. He's the medical lead for eHealth here at NHS Greater Glasgow and Clyde. Andrew was quoting, you'll see this in the chat box, quoting from Deming, saying that eliminate slogans, exhortations and targets for the workforce, asking for zero defects and new levels of productivity. Such exhortations only create adversarial relationships. Now, he goes on to quote Deming further, but his question comes up in the form of, he says, we keep trying a range of platforms to facilitate networks. The best seem to him to be curated and have good technology. He mentions QI Connect, illustrating a positive example there. Thank you for that, Andrew. But he goes on to ask, however, in our current climate, there's no budget made available for such facilitation with additional funding for formal managed clinical networks. How can we convince funders to invest in professional networks to create communities of practice?
Yeah, that's a great thing. Firstly, I think that we can start doing community of practice ourselves with very little money, actually. For the managed network is quite important. So let me take my perspective, because I have tried a number of networks in the past. Brian, you might know, I was running the Health Foundation Network for a while, and it does take a lot of time and input. And Dave, who's sitting in Toronto, is running our International Pediatric Patient Safety Network, which requires someone to do. So you do need a bit of resource. But a lot of it is something that we should incorporate within our normal jobs. I can quote the Battalion one that's always used to have 2 jobs. But I think that really what we need to do is build the case more strongly. If you look at those papers from Braithwaite et al. On networks, they give some of the issues that make it difficult for networks to work. The lack of equality within the networks, being overmanaged, having a common goal. And I think we need to start small, build networks within our areas. Communities of practice or something that people come to together. Speaking from the role of ISQua, what I'm trying to do with our team here is to move to where we can provide the platform to work with other networks. So working with the network we're on at the moment in Scotland, how can we link that network to a network, say, in Taiwan, we've got members in that area, or a network in China that we may have links with. And that's where we go. So we can act as an international network at low cost. The key thing to do for me is that there is not much money left in the system. It's how can we use the money in a better way. I think that's where we're going to have to find funding, because currently I don't think we'll get much more money out of the system.
Thank you. And again, the money out of the system piece, Stuart Ferguson, who's the Scottish Clinical Leadership Fellow with the Royal College of Physicians and Surgeons in Glasgow, comments that he very strongly agrees with the comments you're making around what we learn from low and middle income countries around reverse innovation. It's called developing countries. Anything that stands out for you in terms of that innovation, Peter?
Yeah, so one of the reasons I started in this role, the first thing I'm doing is doing this work in Mozambique, is that I'm learning about how a network can work. So what I did with them in Mozambique, I said, look, I need to know how you are doing. And so what we did is we set up a WhatsApp group for all of the participants. Last there in August, I'm going there next time, and I get every day in Portuguese. Mind you, I don't understand everything they're saying, but I understand the activity and how they're networking with each other on WhatsApp. Now, I are very few of us who do that on our collaboratives, in which we do it and we send WhatsApp daily reports to each other and asking each other questions. It's a simple thing. So what it is harnessing something that is totally free and to do. And how it works is that I have someone saying to me, when I have to intervene, they'll translate for me. But what I'm counting is the number of activity of people working together. So that initiative of people saying, what's the best way we can do this cheaply, and how can we communicate and spread ideas in a real way? What's going to happen here is that after 6 months, the community of practice of people who've been working together for 6 months on their projects now will expand and get more people together. So I'm learning that you can use simple things in an effective way, even if you don't have resources. resources.
Great, very much for that, Peter. And I know that the Scottish Quality and Safety Fellows use WhatsApp all the time. They've got excellent groups on there. We've a comment here from Liz Murphy, again a regular QI connector. Liz is a rheumatologist in NHS Lanarkshire and the chair of the Scottish Rheumatology Society. Liz is saying, regarding resources, if clinical networks can be shown to improve the effectiveness of care and reduce waste, they will save money.
Agree with that. I think that what we failed with the clinical networks is that we haven't put the fundamentals in right from the beginning, and I'd argue that one have a health economist right at the beginning of without a clinical network is to have that right at the front to say, well, how can we demonstrate they are saving money in order to do that? But really, this is not about saving money per se, although that's important. It's really about providing better person-centered care.
Yeah, and Liz has been joining us in the conversation here in Scotland around how do we just get the costs of care and the costs of prescribing and all of that just into the discussion. But previously, clinicians have been somewhat reluctant to bring any form of costs into the discussion.
Well, that's all about professional autonomy. Clinicians do a lot of costs when they work in the private sector. They manage to do in the private sector look at the costs when it costs themselves, but as soon as they come to the public sector, suddenly that part goes. So we do look at it sometime. We do that in our day-to-day lives. We make finance choices based on finance. And I think we now need to do this. I would say that the professional bodies need to take this on hand, and I'm pleased to see that I don't know if it's happening in Scotland, but in England, the Choosing Wisely campaign is starting. That's come from Canada. We had this Wendy Levison at ISQua Forum conference last week give a keynote address on Choosing Wisely, in which you choose your tests wisely, and that brings down cost. And I think that we need to change the way professionals work together in order to make sure that we have cost as part of our decision making. It doesn't mean you're going to give worse care, it just means you're going to give more appropriate care.
Thanks, and that certainly echoes the messages in our wonderful Chief Medical Officer, Dr. Catherine Calderwood's report, Realistic Medicine, which came out this year, where she again emphasises the importance of considering resources, variation, and shared decision making as part of the questions put to doctors and other clinicians. Yeah.
Brian, could I just respond to that one? That's an aspiration, and until we change the way we train our doctors and nurses, but particularly the doctors in medical school and in our training programs, and have that as part of their training, we're not going to get there.
Good choice, Peter. Absolutely spot on. Peter, there's a few comments from people around the social networking and social networking tools. Many people coming in to say how they use that. But our friend David Grayson is indeed awake down there in New Zealand, and David was raising, are privacy an issue for us using social networking tools?
My view is, if you've got a Facebook account or a LinkedIn account, you can create a private area if you want to. So that's true. But really, it's about respect. So is that you don't put patient details on it. If you're going to use patient details, then you should be using social media. If you're going to put concepts and principles, and as long as they're respectful and they're not derogatory and they are in the positive sense providing improvement, then I don't see what the problem would be.
Yeah, Peter. Now we've got just a couple of comments here. We've got Leslie Middlemith, who's an improvement advisor at Scottish Government. And Leslie raises the point around followership. She says followership is really important. The success and failure of groups, organisations and teams is not only dependent on how well a leader can lead, but also how well the followers can follow. What are your thoughts on that?
Oh, yes. So the key thing is that sometimes one's a leader and sometimes is a follower. You can't have a team full of leaders. I always like looking at the sports analogies and I think, David, if you're still awake, why do the All Blacks win all the time? They're a team. The team is more important than the leader. And sometimes they follow, part of the team would follow, and sometimes they would lead, but they understand when they have to lead and when they have to follow. So if you study, sports analogies are a very important way to see how good teams work. And I've already studied the way the All Blacks work. They recently got rid of one of their best players because he didn't keep to the team spirit and ethos. The team is more important than the leader or the followers make sure that the team works well.
Excellent, Peter. Excellent analogy, and just a big shout out to David Mates, the Chief Executive in New Zealand, in Christchurch. When David gave his QI Connect talk, his father and his uncle, I think, were both New Zealand All Blacks. He referenced teamwork throughout his talk, as many of our speakers have. We have Tracy Dunn from NHS Lanarkshire. Tracy was asking around quality improvement at the front line. So how do organisations get quality improvement to the front line?
I think it's the other way around. Is how do they allow the front line to improve? So certainly we've got to go back to Deming. We've had quotes from the 14 principles, and one of the principles is allow workers to have pride in their work, to that effect. We don't allow workers to have pride in their work. Workers are proud of their work and involve authority to continually improve the work to the front line and allow them to do that, and they'll continually improve. That's the ethos. Now, what we do here is, for example, and I've had this with numerous medical doctors, is that they have problems with prescribing, the way they prescribe, or problems with the way they reconcile medications. And when they want to make changes, they have to go to a drug committee, they have to go to the clinical directors, the CEOs, et cetera, and it's just far too difficult and far too hard to do that. And as you can see, one of the recommendations I made earlier is the need to simplify. Simplify and allow the front line to improve without making it difficult. Often when I say that, people come back to me and say, oh, well, then we won't have standardization. Well, in an organization in which you have the right principles, you have the right goals, and people all work to a common purpose, they will standardize, but they will continually improve.
Peter, and that kind of echoes some of the points made by Debbie Banks, Senior Lecturer in Mental Health Nursing at Robert Gordon University, where she's saying that of the 6 learning themes, quality is in there and is a core part of the development for the students. And hence, if your point, then going to the front line, going to the students, going to those in training positions might be a good place to start. Now, come to the end of the talk, I'd like to thank Tom Gibb, the Ops Manager at Salus, which is an NHS provider of occupational health. Tom was echoing many of the points you were making earlier in the talk. Peter, particularly around quality improvement circles and some of the examples from industry. And a thank you to Tom Houston, Health Improvement Specialist at NHS Forth Valley, for his comments throughout the chat box, and many other chats. So, Peter, it just remains for me to say thank you so much for joining us today, and thank you, Jenny, for helping as well today. Super call. This is just a slide reminding us of the wonderful QI Connect lineup that we've had this year. Jennifer works really hard to link in across the world and look at the expert international speakers that we're getting as a result. Delighted to say that George Kerwin, the Chief Executive of Berlin Health, will be joining us on the 10th of November. And November is a big month. We have 2 QI Connect sessions with Tim Brown and guests. Tim is the Chief Executive at IDEO. And some wonderful surprises for you in that episode on the 22nd of November. So a big shout out to George Kerwin on the 10th. Thank you to everyone for joining us today. You can follow us on HISQI Connect, big thank you to Peter Lachman and all the team at ISQua. Shout out to Caroline and Sinead for doing such a super job in bringing today's show together, along with Jennifer and Ross. Thank you very much, folks. Have a great rest of the day.
Thank you.